Thank you very much, Rose. It's really a pleasure to be here and to hear the UK model too, and to hear all that's happening. It's a very exciting time actually in education, but you can already hear from the questions, we're all challenged, like how do we keep busy clinicians, up to speed with some of all the new technologies and science always coming down the pipe. I'm going to give some background into Souza. It started out on nursing, but actually we're in all the professions right now. But I want to tell you a little bit about the history. We have the same problems we all have. We actually are doing a lot in mental health, so there might be some opportunity to do some things together, I think. But we have, the problem in cancer care is that it's growing. And people are living longer, but there's a huge population. And really the quality of care was not there. This started in 2008. We started out in nursing because the money from the ministry was tied to nursing, but they play a critical role at the front line and really did not have in some cases, specialized high level of training to do the complexities of oncology care. And it's the same thing in palliative care. We also have a high rate of attrition. Palliative care is also growing, and I know UHN is very engrossed in very long discussions about how to deal with the palliative care strategy, particularly in acute care, because really your frontline clinicians know very little about current palliative care models and how to have certain conversations and the mental health and existential distress involved. So it's another area that we're moving into very quickly. But we wanted to create a specialization model. We needed more people in the field. We needed to keep them in the field. And although there was a national certification exam, the nurses actually weren't writing it. Only 25% of Canadian nurses were writing the exam. Now this is Ana Maria de Souza. She actually did fundraise through her Brazilian ball in Toronto for almost every hospital in a room. They did not put the money up. This was funded by the Ontario Ministry of Health in memory of her because she had done so much fundraising for all the hospitals pretty much in Toronto and the universities, U of T as well. And so we had 5 years of funding, a good pot. It was an incredible gift to nursing. They wanted it tied to nursing because she asked for that and because she died of ovarian cancer. And she actually said to her husband and the staff, she did not feel the oncology nursing was superior, to say the least. And so we were able to write a proposal for 3 years of funding more, and now I'm in the midst of discussions for 2 more years, and we are going to be getting it funded, I hear. But that's a whole other story, keeping these things, I don't know if Dr. Cross is still here, but keeping these things still funded. So the Institute was in oncology. It started out in nursing. There was no mandate ahead except it was to help busy clinicians keep up to speed. It was about education, but for quality care. We used telemedicine, we used online at the beginning, we did many, many workshops, we do use simulation, and there's no other institute like this in Canada. This is the mission. It's to actually help people at the bedside to keep pace and to do quality care, which is why we're here. Now, I have to say right from the beginning, we thought about this in relation to quality, indicators, and performance. It was really about care. It's not just education. It's in the context of clinical care. So the learning has to be really relevant and clinically meaningful to busy frontline clinicians. And we're working within education systems, but we're also working with the Ministry of Health, and we're linked to 14 regional cancer hospitals in Ontario, as well as communities. We have 35 courses now across everything from prevention to end-of-life care. I'm part of psycho-oncology, that's what I do, so every single course has embedded psychosocial guidelines and psychosocial care strategies. That is something we did from the beginning. And we didn't start out mainly online, but now we're about 95% online. Sometimes we have mixed models where we do online, and then because of the competencies, they have to demonstrate something in person. So an example of that would be a chemotherapy program where on the 3rd day, they might do 6 weeks of online training, and then on the 3rd day, the last part of that, we have facilitators all over the province where they demonstrate and measure the competencies. So we went online more or less because of the access. You're going to see the numbers in a minute. I had to be convinced. I'm a psychotherapy person, and they've convinced me what you can teach online, the clinical simulation, the interactions, the community-based practice, and we're using Moodle. But this is really about standardizing standardization across the province, that everybody gets the same level of training and has to maintain it no matter where you live in Ontario, so that the Ontarians have the same level of cancer care. We're partnered with Cancer Care Ontario. I will underline how important it is to be partnered with provincial bodies or stakeholders or the people responsible for the indicators that are going to be asking you to report them. This is just an example. I'm not going to go in and show you the online, but we do have screening for distress and management. We're just rolling out an anxiety and depression course now. You can go in. There's gaming involved. It's interactive. You know, the course on compassion fatigue. We share a lot of clinical cases that kept us up at night. We interact a lot. Sometimes we use standardized patients. Sometimes we do in-person workshops. And we put the guidelines in everything. And because we have our own online Moodle team and instructional designers, multimedia IT, we can keep everything up to date. And they get out of date. Like, I can't believe how much chemotherapy even gets out of date. So our guidelines keep changing. That's important to keep things current. Everything we do is measured. Everything is pre and post measured. Sometimes we're measuring with qualitative studies. We sometimes are writing grants to measure it, but everybody's at least measured for confidence and knowledge level. And we do that also to refine the courses and to keep them getting better so that the educators get the feedback. So I'm just going to go through some of the achievements before I go to the interprofessional model, but we, I think, got funded again because we exceeded all of the indicators that were set out in the original proposal. We have 7,300 learners now across Ontario, and we've signed 4 national partnerships. So we are now national, and for example, Alberta is hiring us to do a strategy for the entire province. We have more than 35 courses. We are keeping the online component innovative and updated, and we've had an 80% jump in certification on that national exam, which to me isn't the big panacea. It's a good first step of certification. But 80% of the nurses in this province have now written the exam for oncology or palliative care, and there's some of the other provinces. So now we have a partnership with the Canadian Nursing Association. We have mandated with Cancer Care Ontario now to give chemotherapy in the province. You have to do the program with us, and you have to maintain it every single year. That's a big coup, because once you start mandating it, then you're really talking standardization and quality and how you start to really, I think, shape the system. It was a big deal to get that. And then we have some graduate level programs. I was looking for a university to step up, and it was Windsor that went with it, to do a partnered certification program at the graduate level. And this is now open to all health professionals, not just nurses. It's for any professional that wants specialty in oncology or palliative care at the master's level. RPNs are an issue. People are hiring registered, what do you call them, practical nurses. We'd rather not so much in the cancer system, but they're being hired because they're cheaper. So we do care, like, you know, we have to get them certified. I'm not in the debate about whether they're, you know, the best or not. They need to be specialized, just like everybody else. And I just wanted to show you that this was important when you're dealing with ministry funding. Like, Premier McGuinty gave the money for this, and he did not want this downtown Ontario, Toronto. And you can see that we've hit all the LINs. Our indicators are reported. We have facilitators all through the LINs in Ontario. We have mentorship programs on career development, as well as we are developing a clinical mentorship program for people who have done the programs that stay with us. This is about lifelong learning. Now, I'm going to talk about this because we're doing this for the other professions. We started out with these, because one course, the shortest course is 10 hours. The longest is, 50 hours. But you know what? I think somebody said it. One course, by and large, is not going to change that much. So we have actually, sort of like based on the Macmillan model a little bit in the UK, we have a core curriculum on top of that national exam, including a clinical fellowship to create something which I think special now, the new Souza nurse, which is catching on, and I think offers Canadians something like we have in the UK, which are highly specialized, well-trained palliative care nurses. So we have them in oncology and palliative care. And now we have designations. These are based on a credit system. There are clinical trainings involved. We help the nurses do this. Most of it is online, not all of it. And we have even got the newest one is an intern level. I was just talking to an undergraduate student so that we can start to use it as a recruitment strategy and train the undergrads from a novice to expert, start to get some specialization going in. But we have it at the APN level and the PhD level. So the main one will be the Souza nurse in the middle, which I think represents a highly trained palliative or cancer care nurse. But you know what? It made no difference to just do nursing. And I never wanted it to just be nursing, but that's where the first 5 years of money was tied. When I went through the next proposal, we could open it up, we could charge, and we could go outside of Ontario. So now we have a interprofessional framework, and John Hunter is here. We put together an interprofessional group to think, well, how can we think about shared competencies, and how can we do something similar for the other professions? And we were asked by radiation oncologists and chaplains, how do we have a designation? How do we get people more specialized in providing the care? And so this is quite a multidisciplinary team. And they worked for about a year. And their main reason is, no matter what school you come out of and no matter what level, none of us can take that degree or whatever it is for lifelong without adding to it. We basically are coming out as generalists as well, and certainly nurses are, but so are most of the other professions. There's an explosive amount of scientific knowledge. We have to have specialization because you've already heard about all these comorbidities and all the challenges at the front line, no matter where you're working, in the hospital, at home, wherever. And the education's quite fragmented. We don't learn together. The universities don't talk to the continuing education necessarily. It's not usually integrated. We're usually learning quite a bit in silos, even within your own field. We have a mismatch of competencies. We have poor teamwork at the bedside, I have to say. And often I'm seeing clinicians with too highly technical focus and not the psychosocial care focus in the other pieces, which is probably why we're talking about patient-centered care so much. And episodic encounters where we really need continuous models, as well as health system performances. So this idea of tribalism in our professions and not learning together, even though we've talked about interprofessional models for years, they're not happening that much. So we need joint solutions, competency-driven approaches. We're trying to think about what is the common set of values. So this is what our team has come up with, this group. They have developed an interprofessional model. We're writing the paper, which covers all domains of the medical area of cancer by domains of knowledge. There is a sense that the patient's in the middle, but no matter who is on that team, needs to have a shared set of competencies. But it's a novice to expert competency-based model. So you're a generalist and you have increasing levels of competencies. And with every level, I can't go back now, but with every level, by domain, we have a competency for skill. These are the baseline ones. These are the ones we have to know in general, the patient-centered care, the communication type ones, awareness of your ability to take care of yourself and your limits, compassion fatigue. But there's this idea that you come out of school, there's a novice to expert pathway across every domain, and we have competencies within each domain of knowledge, as well as each level of practitioner to create the increasingly specialist of the Souza health specialist. So it could be a psychologist, could be a social worker, could be a GP. The GPs in the community want to hear about survivorship issues because they're going to be getting that. And we are getting buy-in into this. We've been asked about this quite a bit. We have a learning pathway attached. We help people go through it, and it's, they can do it. So these are the competencies that you're not meant to have to see them all. I can give you the document, but we have spent a lot of time by that domain. And I think this is actually quite useful in any disease because it's the same kinds of things that we're dealing with. And these are just some of the examples. So a psychologist, for example, I didn't have one, but I could have used a course on the foundations of cancer, the tumor sites and, the treatments. I learned everything from the surgeons and the patients. I came with a mental health background, but I actually didn't know the medical stuff as much. So we are suggesting an oncology foundation course as one of them. And we have competencies for attitudes and skills by level. And then what we're going to do is map our pathway of courses to this, help the managers do this. And we're marketing them as packages. Health agencies are buying them. A lot of people want their health agency to buy the courses. And we are actually positioned now with the ministry to really look at all of the areas from senior care to mental health, because we have quite a bit. We have 6 courses now in mental health that could be easily, by adding in different cases, to the other areas. I know that Reno has talked to us. So that's sort of the background in a nutshell. It's been a few years to get to this level, but I do think I'm really happy to be here and maybe tomorrow. I do think there's leverage to partner and convince the ministry. Like, I'm quite happy to write proposals with people to think, like, we should be going together maybe. And it's been a proof of concept that nobody predicted we'd get 7,000 people. It could have easily been a project that just kind of got shut down. But if there are some things that might be of interest, or the competencies or whatever. So I'll just finish there, but I'm delighted to be here and answer any of your questions. Thank you.